Very good morning, one and all. My name is Dr. Karthikeyan. Currently, I am working as a senior clinical researcher cum clinician at NIMANS, Bengaluru. My terminal degree is postdoctoral fellowship in physical therapy completed in 2018. So, my end title of the topic is treatment of OA knee. So, this lecture going to cover overview of the OA knee, clinical approach to the knee pain, differential diagnosis, diagnosis of knee osteoarthritis, then what are all the treatment that is called management, mainly for lifestyle modification, medical, surgical and physical therapy management, that is going to discuss. The second slide which describe about some of the questions which we have to consider before discussing this lecture. Consider what type of physical therapy exercise and advice are appropriate. How might you facilitate behavior changes? How can you encourage an ongoing exercise and activities? What advice can you give to a patient exercising in the presence of pain or comorbidity? What information can you provide? Can you refer to any other medical services, especially medical management, dietary services, followed by rehabilitation care, then some surgical intervention which is required or not, decided by whoever they are approaching, including physician, they have to refer to for further management. The next overview. The knee osteoarthritis most common. Knee osteoarthritis is the most common cause of disability in adult. Especially if you compare with male and female gender, female is more prone to get affected this inflammatory disorder. Decreased work productivity, frequent sick days, highest medical expenses of arthritis condition, symptomatic knee osteoarthritis. More than 10 million Indians who they are suffering this kind of osteoarthritis day to day life. More than 11% of person, especially the age above 54 years, they used to get osteoarthritis is more common. Arthritis versus arthrosis. There is a gradual loss of articular cartilage in the knee joint. There are three articulations. One is lateral condyle of the femur and tibia. The second one is medial condyle of the femur and tibia. The third one is patellofemoral joint. This slide which describe about difference between arthritis and arthrosis. Damage caused by a complex interplay of joint integrity, biochemical process, genetics and mechanical forces. The anatomy of the knee joint. The knee joint, it is a knee complex which is mainly consist of, there is a thigh bone and tibia and patella. The lower part of the thigh bone, upper part of the tibia and patella going to create a knee complex. That is the anatomy of the knee joint. The next slide which describe about clinical approach to the knee pain. My knee is been hurting. The patient used to tell. So we have to take assessment, subjective, objective, assessment and treatment plan. There is a Socrates scale which help to assess the pain intensity. Followed by, there was a clinical symptom, mainly inflammatory changes, fever, hot joint, history of trauma or surgery, instability, functional loss and period treatment. Clinical approach to the knee pain. Clinical approaches, this slide, it helps to assess the physical exam. The second one, vitals. The third one, palpation. The fourth one, range of motion. Fifth one, stability, alignment and function. Function mainly gait and waddle, tuck walk and waddle gait. Clinical, the next slide which describe about clinical approach to the knee pain. So here there is a test we called as valgus test and varus test. Valgus test to identify the medial collateral ligament, varus test which will help to identify the lateral collateral ligament. Patient is supine lying, we ask the patient to 90-degree stability, then we give the stretch to the muscles, ligament, then it leads to pop click sound came, the test is positive. Then another one is Lachman test, it mainly assesses the ACL ligament tear. Fourth one is Mac-Moray maneuver, that is a meniscal tear. Fifth one is tuck waddle, it will help to assess the stability of the knee joint. The clinical approach to the knee pain, especially these are all the tests which will help to identify the diagnostic tool along with some of the blood investigation, that is ESR and rheumatoid factor we need to assess, arthrocentesis, X-rays. There are three views we need to check. One is weight bearing view, that is anteroposterior view. Second one is lateral view. Third one is tangential patellar view. Then MRI. MRI, it will help to identify and changes in the knee pain. Then differential diagnosis, we need to consider four component, that is medial pain, it is due to medial pain, it is due to lateral pain or diffuse pain or anterior pain. The pain in the medial side, if it is persisting, we need to check what is the why it is happening. That is called, it is due to medial pain, maybe osteoarthritis, medial collateral ligament, meniscus and bursitis. Lateral pain, we need to check again osteoarthritis, lateral collateral ligament, meniscus, iliotibial band syndrome. Third one is anterior pain, that is osteoarthritis, patellofemoral syndrome, prepatellar bursitis, quadriceps mechanism. The last one is diffuse pain. We need to differentiate, that's why these four component we need to check and we need to assess. That is called diffuse pain. Last one is osteoarthritis, infective arthritis, gout, pseudo-gout, rheumatoid arthritis. Diagnosis of knee joint, especially classic clinical criteria established by ACR 1981. Knee pain plus at least 3 of 6 characteristics. One is above 50 years people used to suffer both gender, morning stiffness, it will be persist more than 30 minutes. There is a crepitation. When you move the knee joint flexion extension, there is a crepitus sound which will be exhibited from the knee joint. Bony tenderness, bony enlargement, no palpable warmth. The diagnosis of knee joint, mainly for synovial fluid we need to check. X-ray, there is a changes in osteobite formation, loss of joint surface, subchondral sclerosis, subchondral cyst, confirmed by arthroscopy. Diagnosis we can confirm through X-ray, CT scan, MRI. There is a changes. First, normal knee, the gap between the tibia and the gap between the thigh bone, lower part of the thigh bone and upper part of the tibia, if it is normal, it is indicating this slide. The second one is there is a narrow joints. If you compare with the lateral side and medial side, the lateral side is more deviation to the medial side. Then bony spur also we can check in this X-ray report. The third, another report, the last one is the lateral side, lateral condyle, automatically it's connected with the medial condyle. So there is a less gap, it is indicating there is a osteoarthritis. Now we can discuss about lifestyle modification. So the patient already, it is a weight bearing joint. So the patient already more obese. So we have to advise for dietary consultation followed by weight loss, wellness and fitness. So proper nutrition they have to advise. What are the exercise which will help to reduce the weight reduction, because upper body weight is more, automatically the pain accumulating joint, it will increase the pain. So we have to focus, there is a stretching, strengthening along with the isometric exercise. So quadriceps strengthening, range of motion exercise, low impact activities mainly for swimming and biking. Ambulatory assistive device, mainly we are using can and walker. Then orthotic advices, insole modification, unloaded knee braces we have to advise to the patients. Then followed by management of, there is a valgus and varus. Varus means bow legged, valgus means knock kneed. So there is a changes, it is indicating bow legged and knocked knee, that is valgus deformity. Unloader, this brace which will help to adjust the knee joint whatever the impairment is there or pain level, automatically it will help to adjust. So that is called knee brace, which will help to keep the knee in neutral position and which will help to reduce the pain, that is indicating. Management mainly glucosamine, acetaminophen, non-steroid anti-inflammatory drugs which we have to perform. This is the medical management. Then we can go for some of the steroids. Its severity is more, then we can advise the patient to undergo for steroids. So steroids will help to reduce the pain and improve the quality of life. The next slide which describe about acetaminophen, indomethacin, these are all the drugs which will help to reduce the pain. Then we can go for medical management is over. Now we can go for intra-articular injection. The patient position is supine, legs straight, manipulate patella, ankle needed slightly posteriorly, inject after drop in resistance or fluid aspirated. That will help to reduce the pain. So what are all the advices we have to give? Lifestyle modification which is performed through wellness expert, dietary expert, along with some of the steroids, the non-steroid anti-inflammatory drugs. These are all the things physiotherapy which will help to restore the functions. So another, that is a surgical intervention we called as high tibial osteotomy. So this high tibial osteotomy, it will help to realign the upper end of the tibia and lower end of the tibia, upper part of the tibia and fibula. It will correct the correction and the repair, all those things. So another surgical approach is TKR, total knee replacement, that also will help to restore the function. Then these are all the exercise. The patient position is knee squat. Another exercise leg cross, which will be help to strengthen the quadriceps as well as other joint muscles. So mainly we have to perform 1 minute rest and repetition of this exercise knee squat at least 2 times. The same this leg cross, the same position, sitting in the stool or sitting in the chair, we ask them to extend the knee, hold for 5 seconds, rest 1 minute, repeat for 2 times. The third one is muscle stretching exercise. The patient position is supine lying. The affected side should be knee straight position, unaffected side knee should be flexed position. Then we keep the position for 5 seconds, rest for 1 minute, repeat 3 times. Then step up, stair climbing activities. This ask the patient to stair climb. We keep the position 5 seconds, hold, rest 1 minute, repeat for 3 times. The third one is sit to stand exercise. Sit to stand, which we can perform through chair. So we ask the patient to sitting position at the edge of the couch. We ask the patient to sit. We ask them to get up from the chair. So the holding time 5 seconds, rest 1 minute. Then repeat for 3 times. Then last one is take home message. Overall, this medical surgical physiotherapy treatment approach, which will help to minimizing symptom and maximizing function of osteoarthritis. This intervention which help overall health, well-being, wisdom, gait, balance, flexibility, joint range for osteoarthritis. Thanks for giving the opportunity to share my knowledge, experience in this osteoarthritis for the management of the physiotherapy approach. Once again, thanking you.